People are living different pandemics based upon where you live. You're more likely to know somebody who had an infection versus not. Depending upon which racial groups you are, you're more likely to know somebody or less likely to know somebody. We're all living different pandemics.
It's just really disheartening to see that, yes, a business can set things up right, but if people don't really care and behave however they want, it's just going to amplify the virus.
One of my wife and I's favorite activities to do is to go hiking. And people always say that the majority of accidents hiking actually occur on the way downhill. So we have to stay vigilant. We have to be aware of the fact that just because we may have peaked already, it doesn't mean that this thing is over, that we have a long journey still ahead of us until we get through the thickest part of the woods.
Hey everybody, welcome back to the Vitalyst Spark podcast. I'm your host, John Ford. 2 weeks down the timeline from our last dialogue on the pandemic, we're back at it again, following a unique Memorial Day weekend no less, with our next COVID-19 Roundtable. Recorded on May 26th, we start with the numbers, keeping in mind that the story they tell today reflects the actions and community behaviors of roughly 2 to 5 weeks ago. Roundtable member Nick Vasquez, featured in May 25th's Arizona Republic article on healthcare worker burnout, takes us on a tour of his current emergency room physician life. Will Humble, featured in May 27th's Arizona Republic article on increases in hospital capacity, continues his insights from a public health perspective. And Marcus Johnson brings it all around with key policy perspectives. If you're not familiar with the term pre-vaccine pandemic yet, well, that's probably because we coined it in this episode. But you will be familiar with it, what it means, and what it tells us by the time you've listened in. So let's get to it. It's time to talk about the delicate balancing acts going on with systems, policies, environments, and people in the pre-vaccine pandemic era of COVID-19. We are back with another COVID Roundtable today, May 26th, the day after Memorial Day. And joining us once again for the Roundtable, we have in the studio here, Mr. Will Humble. Will, how are you today?
Howdy, everything's good.
Glad to have you back. And also joining us, we have Dr. Nick Vasquez. Nick, how are you?
I'm doing great. Thanks for having me.
And as always, my colleague, Marcus Johnson. Marcus, how are you?
Good afternoon. Doing well. Thanks for having me back.
Guys, thanks for joining us. Let's get started. We are on the eve of 100,000 deaths in the United States. Let's put that into perspective. What's been our journey so far? Where are our numbers today? And what are we looking at? Will?
You mentioned deaths, so I'll go there first. The big deal is it's congregate settings that are driving the deaths. So if you look at the numbers, you'll often hear that it's older you are that you're higher risk for death. But really, it's a combination of being older and living in either assisted living or skilled nursing, because the data is dominated by those settings. The outbreak in the Navajo Nation, that aspect of it in Arizona too. But I think the big thing when it comes to death, when we do a retrospective on what could have been done better throughout this epidemic, it was to be a lot more focused about assisted living, skilled nursing, and seeing what kind of things that we could have done at the beginning to protect folks better in those settings, because that's where the deaths are coming from. There's data that really shows that if you're older and living at home, you're at, yes, an elevated risk if you get it, but the numbers are with those congregate settings.
4 weeks ago, people were freaking out about the idea of a projection of 100,000 to 240,000 deaths. Now we're on the eve of it. Are people even going to notice?
We talked about this before we started about the perception of risk. So I think it depends on who you are. There's some people, like my parents, for example, they're in their late 80s. They're taking it pretty seriously. But having said that, they're pretty lonesome.
Yeah.
And so they're starting to do some social events with people from church that they wouldn't have done a few weeks ago, even though the risk to them is the same. The numbers, the spread in the community hasn't changed very much at all. But the loneliness has driven them to take more chances than they were. So the answer to that question lies with the beholder.
Yeah, fair enough. Marcus, ADHS website, what's it telling us these days?
When you look at the data for the state, I think that the two most important pieces to look at really are the hospitalizations or the rate of hospitalizations, and then also the percent positive rate. Over the past month or so, the state health department has been doing these testing blitzes, which really is a critical thing for us in Arizona to be doing because our testing numbers were just subpar, far behind the rest of the nation. So now we're doing these testing blitzes where we're actually able to put out a whole lot more tests. And so naturally, we're going to see the number of cases rise just because we're testing more people. But the thing to really pay attention to is the percent positive rate. And fortunately, over the past couple of weeks, we're continuing to see a decreasing percent positive rate.
Marcus, let me jump in real quick. For the listeners, urge them to go to ASU Biodesign website. So what they've got on there is a percent positive by day. And what the state health department is doing is grouping the data by week, giving you that kind of granular look and watching how the percent positives jump around from day to day. It gives you a different perspective about, is it really decreasing or not? So I'd be careful before you conclude that there's actually a decline in the percent positives of the PCR tests.
And I'm glad you mentioned that too, because on ASU's site, they do a great job of also breaking it down by county. And so, when you look at statewide numbers, you might develop one narrative, but when you look at county by county numbers, you can see that there's variation. To Will's point, some counties, you do see a decreasing rate of maybe like new cases. At a statewide level, the ASU data shows that there is a decreasing rate day by day of cases, but in certain counties, it's not that clear. Like Yuma County, I think, is one example where the daily rate is still increasing. It's not as high as like Maricopa County. There's so many more people in Maricopa County. But the point is that, statewide numbers are one thing, county by county numbers are something else to really pay attention to.
It's just interesting to look at what's happening county by county. Like I've been to Yavapai County more than once. I've been to places, there is very little social distancing, hardly any mask wearing going on. And yet you look at Yavapai County and over the last couple of weeks, their cases are dropping. And there's other places like Santa Cruz County and Yuma, like you mentioned, where they're going up. Maricopa County is so giant, it's kind of like a state in itself. That's sort of been the steady climb. But I think they've done a really nice job on that ASU site. I encourage everybody to go there because it gives you more granular detail than you're going to get on the state site.
So is that the answer to the question I was going to ask, which was if there's one place people should be going, because everybody's an amateur epidemiologist now, is the place to go the ASU Biodesign Institute?
No, I think you need to go to both.
Okay.
Because there's a lot of stuff on the state website that ASU Biodesign doesn't have. But there's more detail in some really interesting areas like the county data, day by day percent positive, and some other trend stuff on the ASU site that's not on the state site. So I don't think you could say there's one place. I need to go to both now. I used to just go to the ADHS site. Now I have to go to ASU before I talk for something like this.
There's a website I'd recommend if you do want a one-stop shopping. There's several different options. There's the COVID Tracking Project or covidtracking.com. It's run by The Atlantic. There's Our World in Data, which is a fantastic data-driven site. The one that I do trust for me as a physician, the one that I'm following, which is not dependent upon how many tests there are, how many cotton swabs or any of that, is just the hospitalizations.
Yeah, that's me too.
You can follow that trend. It's not contemporaneous. It's 1 week to 2 weeks behind sort of the trend, but it really tells you kind of the arc you want to see. Are we getting better? Are we getting worse? What's the situation? Because the most severe disease is just going to require hospitalization.
So where am I going to go to find that as a consumer? And what does the data tell you right now?
For Maricopa County Public Health will put that out about once a day. And it tells us that the hospitalizations are declining, along with the idea that, hey, maybe we've passed the peak for now. The relaxation of some of the stay-at-home orders, there's more room for that. The hard part is there's no one number that tells you the whole story. So my third rail still remains hospital capacity, which isn't just hospitalizations, but it's the ability to give critical care. So that's ventilators, ICU beds, ICU docs, nurses, pharmacists, respiratory techs, the whole team. Just saying, hey, well, we've got enough ventilators is like saying we have enough car engines, but we really need wheels and a frame and a seat. You need all these things to work together to make critical care work. And at the moment, that's the one thing that can save lives. The sickest people need really good critical care, as evidenced by that one Chandler doctor who spent 55 days in the hospital on ECMO, which is a machine that does the breathing for him, actually does the gas exchange for him. And if you didn't have that, well, there's one more death out of the 100,000 that we're getting to. Right now, that's where we're saving lives.
Nick, you appeared on the cover of the Arizona Republic today talking about the subject of, quote unquote, the wheels, if I may. and the idea of healthcare workers and burnout. Talk a little bit about that.
In the article, I said one of the things I believe is that medicine is three parts. It's one part a calling, that you care for people. It's another part a profession where you learn how to actually do the job. And it's the third part a business. I don't technically get paid for seeing people. I get paid for filling out charts of paper or electronic charts and then submitting them for billing, which is completely separate from the part that drew me to medicine, which is I care about people. One of the biggest problems with emergency medicine and burnout is that you end up getting pulled away from the calling part and you have to focus on the business or the profession. You don't connect with the purpose of what got you there in the first place, of caring for people. The second thing is that in general, it's hard sometimes to care for people who've had a lot of trauma in their life. They're very difficult. And they require healing and a different approach. And it's not something you can just write down in a prescription and say, hey, I'd like you to take perspective every day until you feel better about the things that have happened to you so you can hear what I'm trying to tell you about the smoking that I want you to quit. A lot of people burn out that way. Now with COVID, every patient is a possible threat, not just to me, but also to the people I love and live with. And so I can't connect with patients. I can't connect with the mission that I'm there for without seriously contemplating the risk to my health, my livelihood, and whether or not my kid or my wife is going to get sick. I can't consider myself no risk. I have to wear a mask when I go outside. I limit what I do. I haven't seen my father, who's in his 70s, for months now, unless it was video. I am an independent risk factor for the people that I care about. That makes it really hard to connect with the mission, really hard to not get frustrated and fed up, and really hard not to see people as a potential threat. It requires work on my part and all of our parts to get those emotions to process and let go of. That's what I was trying to talk about.
A couple of weeks ago, we had an episode on first responders where these guys are literally setting up tents in their garage and not even coming into their house.
Yes.
What creative solution can there be to help support frontline workers who are taking these risks?
It's hard. Each of us have developed our own defense mechanisms. You might call them superstitions, you might call them reasoned or thoughtful, but across the country, all of us have developed these rituals of decontamination coming in. I know a friend of mine, she has a pair of scrubs she changes into at home. She goes to the hospital. She puts on hospital scrubs, leaving the home scrubs in a locker. She wears masks and face shields all day, and then basically goes and washes, changes back into hospital scrubs, changes her shoes, drives home, in the garage, gets out of those scrubs, puts them in a laundry in the garage, showers, and then changes into clothes before she sees anybody. That's a lot of us. Some of us have even gone so far as to move out. So I don't know how you change that unless you get a vaccine and this coronavirus goes away. But this goes back to how can you support people? Your question, take this seriously. It is so disheartening to walk out and to see people around a pool or to see people in a restaurant. The idea of them wearing a mask is like anathema to them. They think it's like somebody with a brown shirt telling them to line up over here. I can't tell them how much that makes me feel like you don't really care about what happens to me or my family or my brethren. You don't really care about all of the healthcare workers that are getting sick and some who have died. It's another emotion you have to work through so that you aren't left with these negativities. I don't harbor negative feelings against people. I've just experienced a lot more of them, and I've had to work through them and let them go.
This really brings us to the greatest public health challenge of this time, does it not? Which is how to balance the economic nature of this with the healthcare nature of this. And as we move into this phased reopening, Will, and we talk about the details of mitigation or whatever it might be, but this is the balance that needs to be struck.
Yeah. I think when we were here 2 weeks ago, I was focusing on owners of businesses doing the right thing, setting up an environment so that people can come to your business and have a safe environment. Now it's 2 weeks later. The focus has changed for me. It's about the customer's behavior. You can set up an environment, a hardware store or a retail store or even a restaurant and maybe a bar in a way that it can work. You can do mitigation and people can still have some semblance of normalcy as a customer. But what we saw in the last week were all kinds of events where it wasn't the business owners that set up an irresponsible environment. It was people behaving irresponsibly. Disheartening is the right word. Nick said it's just really disheartening to see that, yes, a business can set things up right, but if people don't really care and behave however they want, it's just going to amplify the virus. A couple things in the last week that really got to me. Saguaro Lake Ranch, you can rent kayaks. It's really fun. So it was safe. We were far apart. Saguaro Lake Ranch did a nice job setting everything up, so it was safe and all. But there were just thousands of tubers on the river. And the way they were getting in, they are all driving up to these gathering points. You'd never guess there was a pandemic that was spread with droplets that was lethal. That really struck me, and that was bad. But what was worse for me is when I looked and saw these video clips of downtown Scottsdale in the old town. It's a district where it's a bunch of clubs and stuff. I mean, I couldn't believe it. One of them had a rapper and place was absolutely 100% packed to the gills. And so that's an example of a business owner that didn't give a damn and customers that didn't care and set up a super spreading potential environment. We're going to see what happens. There's an incubation period that we have to go through before we see whether there were some big spreading events for some of those things. The potential's sure there. Those are the two things that struck me the most.
So a couple of headline grabbing things of that nature, Marcus, I'll ask you to weigh in on some of these real quickly in terms of what Will's talking about. There is the famous episode of a Great Clips employee who continued to work while actually feeling sick, and now they think that person has super spread to maybe 60 to 80 people. We've had church attendees who potentially infected entire congregations. Will, to your point about masks and retail, there's a fairly famous now Costco video of a patron who was kicked out for not wearing a mask, and the gentleman saying, "You all are sheep, and I can't believe this is happening." We're all going through a pandemic for the first time. Some of us are learning faster than others. Some of us are behaving better than others. 2 weeks ago, Marcus, we talked about this idea of we've got to move on from flatten the curve to some other rallying cry. Put all these events into perspective and tell us what you think could happen next in terms of that next rallying cry.
I've been kind of racking my head about that. Like, is there another common goal that we're all trying to pursue right now that we see the overall rate of increase starting to flatten? And it's hard to pinpoint. John, you had mentioned, or maybe it was Will, you had mentioned that we're trying to balance the economic demand that's out there along with the public health demand. But I think it's also important to acknowledge that all of us, just as individual human beings, we also have a social demand in order to try to interact with others. That's where also I think that there's inherent risk here, is that Will gave the example of his parents, like just not being able to see people for a very long time. And I'm sure we all have examples of this where we're just trying to do the best we can to hunker down throughout the week over week. And then an opportunity arises to maybe go see a friend or go interact with others. And we all have our different risk tolerances, and I think we all need to do as well as we can in order to try to stay as socially distanced as possible. But we are social creatures, and it's tough to not allow complacency to set in. I think about one of my wife and I's favorite activities to do is to go hiking. And people always say that the majority of accidents hiking actually occur on the way downhill. So we have to stay vigilant. We have to be aware of the fact that just because we may have peaked already, it doesn't mean that this thing is over, that we have a long journey still ahead of us until we get through the thickest part of the woods, until, we're safely able to get back to grandma's house. And so I think that's another important thing for us to acknowledge, is that it's not just the public health implications, it's not just the economic implications, but that, as social creatures, we are inclined to try to get together as much as possible. And it's understandably difficult to social distance to continue doing this. Now, I'm not giving any sort of excuse for massive pool parties and people congregating together and going to see concerts and stuff right now, but it's another important factor to consider.
I want to make sure that everybody understands getting together or seeing loved ones, those are normal human things. In scarcity, when you're lonely, when you haven't seen people, or when you're isolated or you're afraid, it's normal to want to connect with other folks. It's just there are ways to do it to be safe. Keeping a physical distance, masks if you can't keep that physical distance, and good hand hygiene, you can reduce your risk. The one way to definitely increase your risk is to just say, well, it's not going to apply. It doesn't matter. This is all overblown. We tell a lot of stories about coronavirus, but the one that I like to tell right now is that all of our testing, especially here in Arizona, all of our testing shows our prevalence is low, less than 3% maybe. We have a long way to go. Whatever peak we passed, we can rapidly build right back up to it. I don't know what's going to happen any more than you do, but we are just at the beginning of this. And for folks to say, I'm sick of it, I can't take it anymore, is understandable, but this is not going to be over anytime soon. We have to have a very long perspective on this. Maybe for the rest of the year, if not year and a half, our lives are going to be upended by this.
When we start to think about a year to 18 months, then comes in the conversation about, well, what do we have in terms of treatment drugs or vaccines? Where are we on that continuum for something like remdesivir, which now has its third positive trial? We've got vaccine trials. We've got Operation Warp Speed is now in effect since the last time we talked. Even a story of the U.S. pre-ordering a vaccine in up to 300 million doses at a cost of 1.2 billion, even though it's not yet been validated. How should we think about those things?
There are a couple of different things I would start with. So first, let's start with the virus actually itself. And one of the most interesting articles that I read recently talked about how the virus itself blocks the cell's release of interferon, which is a chemical that a cell will make that prevents the virus from replicating as quickly, and also works to start the process of immunity. So it blocks that arm, but it doesn't block the other part of immunity where the cells go running around looking for whomever's been taken over by a virus and releasing these alarm signals called cytokines. So the virus itself is not the damage, it's that over-aggressive inflammatory response from these killer cells running around that release this cytokine storm that leads to the sickest of people, that leads to the organ failure and the lung damage and death. Knowing that means anything that we can use to sort of slow the replication of the virus down might be helpful. But really the thing is how do we kind of mitigate the inflammatory response? How do we help these people who are the minority that have this aggressive inflammatory response? There's not a lot of development. I mean, remdesivir, what I've seen in very small trials, but helping the sickest of sick people, but not everyone in general. And certainly there's not enough remdesivir in this country for anyone to start taking it. I'm still holding out for the vaccine. Me personally, everything I've seen so far is that this Operation Warp Speed, whatever you want to call it, this communal race that we have to try and get a vaccine is, I think, our greatest hope. There are fascinating stuff to read about mRNA vaccines and everything that they're doing, but I believe that that will be the solution that we get to. There's so many challenges to this, but let's say Yahtzee, by the end of this year, we have a vaccine and it works and it's safe and we can deliver it. You can't wait till the end of the year to then go, aha, we have a vaccine. Let's start making billions of copies of it. That would take at least another year or two. You have to concomitantly start ramping up the ability to make a vaccine in large doses without knowing which vaccine actually works, which means you're investing money in the capability to make a vaccine that may never be used. And that's just the risk you have to take if you're going to go at warp speed.
That's really interesting. I hadn't heard that said that way, but it's true. You can't wait for it to be proven before you buy it and start producing it. Yeah, there's a lot to that.
Yeah, that's my terminology, by the way, pre-order. They didn't pre-order it. They pledged $1.2 billion to get it manufactured. That's what's happening.
Yeah.
For a vaccine that has yet to go to trials.
Earlier on some of these podcasts, I was more optimistic than I am now on the treatment side, because I figured there were some drugs out there and a lot of them have been tried. And I was hoping that something would show up that was created and FDA approved for another reason that in some way, shape, or form somehow helps. And the remdesivir is, like Nick said, it's helping some of the sickest of the sick. But we can drive a stake in some of those things we talked about a few weeks ago, of the hydroxychloroquine. Not only does it not help, it hurts. Now we know that because it was a big trial and showed it doesn't help with this.
It's bad when you kill more people than you help.
I was earlier more optimistic that we would have had something as a treatment before we get the vaccine. I'm less confident of that now just because so many weeks have gone by. So many things have been tried. Many of the things that have been tried have either shown that they don't have an effect or are harmful, like hydroxychloroquine. Remdesivir is the example where if you read the study, if someone's in an ICU, would have been in an ICU for 9 days, maybe they will be in the ICU for 7 or 6, something like that. Not exactly a game-changing kind of thing. But on the other hand, both the animal vaccine studies where they looked at macaques, which is like a primate, gave the virus to the animals, and they elicited an immune response. And so that's happening. And then in the European trials, the combination UK-Germany trials, there's safety side of things is looking up. And later this week, I've heard we're going to get some pre-publication data on the effectiveness of some of those things. So lots of things happening on the vaccine front. I'm confident we're going to have a vaccine. I'm less confident that we're going to have a treatment before that's a game changer.
I would double down on that. Viruses are incredibly hardy. They've figured out how to do a lot of things. It's not like you can just create a medicine that stops something that's attenuated over several 100 million years of evolution. It's been an act of frustration for any physician to try to stop a virus. Every year we deal with influenza, and Tamiflu is fantastically ineffective, except for people who are high risk, and even then it's not all that good. Yet we widely take it on the idea that maybe it'll help. Remdesivir the same way for Ebola. We've tried steroids. We've tried anything and everything. Viruses are very efficient at doing what they do, and our body's inflammatory response is the best way we have to it. The immune response is the best way we have to get over a virus. The hard part is that immune response really kind of goes haywire sometimes. Anybody who's got allergies, autoimmune disorders, or any of these people who are having the overstimulation of their inflammatory system are examples of that. We're just not smart enough yet with a coronavirus to know which part in the step of the cascades that lead to viral infections can we interfere with. We just don't have that yet. The more we learn about it, the more we might start to find something like a JAK2 inhibitor, I've heard, or all these different stuff. But how long have we been dealing with this now? Since October or November? And every therapeutic that we've thrown out there has been a maybe or a might be, and none of them have really worked. I would double down that the only way we're getting out of this is a vaccine.
Let's go back to the beginning of this podcast then, when we talked about the fact that, who knows, by the way, by the time this podcast comes out, we could already be at 100,000 deaths. If that is where we are, and we are confident in a vaccine, but not for some time, how do we think we should be proceeding as a country, as a state, as a county, as individuals in a responsible fashion so that A, we don't see another large peak, and B, we prevent that line of deaths from growing exponentially? How do we plan for the future? How do we plan for schools and universities potentially reopening? How do we plan for sports that people want to bring back so desperately? How do we plan for our everyday lives? Where do we go? What do we do?
This thing has been front and center for going on 3 months now. Every single news story is coronavirus. Every conversation you have with your family or with friends over the internet, some way comes back to coronavirus. As frustrating as that is, and as exhausting as it is, to a certain extent, we have to keep it front and center. We have to keep recognizing the significance of this pandemic. And like I said earlier, just doing our best to avoid complacency. I think to the conversation about an eventual vaccine and mass production of a vaccine, the other thing that we really need to be paying attention to is building public trust in vaccinations in general. I've had multiple conversations with people that say, even if we do get to a vaccine, how do I know that it's safe? How do I know that it's actually going to work? They hearken back to some of the rumors that have been dispelled about the safety and the efficacy of flu vaccinations, and they lump in all other sorts of vaccinations within that. So in addition to keeping this thing front and center and making sure that people stay vigilant, it's also ensuring that that people are able to trust when a vaccine comes, that the right amount of due diligence will be placed into testing that vaccine and making sure that it is both safe and effective so that we can get to herd immunity when the vaccine is here.
When we get the vaccine, there's not going to be 350 million doses that come out all at once. You're going to have to prioritize who gets it. I don't think we're going to have a demand problem. I mean, we're going to have way more people that want the vaccine that can get it. I am hoping that there's a thoughtful approach happening at the federal level to figure out what's the process by which we prioritize the initial doses. I think it's a supply problem. It's not going to be a demand problem. There's going to be plenty of people that want the vaccine that can get us to herd immunity. Problem is, who gets it first?
One of the fascinating ideas is if we have multiple vaccines. Gilead, Pfizer, Moderna are just the name of 3 companies all racing to try to find a vaccine. I've seen a study that came out where a attenuated virus that carried a synthetic strand of RNA which coded for the coronavirus spike protein resulted in neutralizing antibodies. And I don't even know which trial that was. There's a ton of people racing to get this. And we may have multiple vaccines in stage 3 trials that look good if the concept is proven. I don't know what'll happen if you have multiple different vaccines and how that'll all work out. Your first question of how do we proceed is just really you divide time into one of 2 states. It's either pre-vaccine or post-vaccine. The rules for pre-vaccine are the same as we've been living for the last couple of months. You have to act as if there's a pandemic. Wherever people are, there may be spread. It's really hard because it doesn't work well with things like school, like economic activity, like freedom of movement, like having airline companies that stay open. There is real impact of pandemic that right now our entire country and the world is really trying to mitigate that. You could say it's loss avoidance, but I like to put it a different way. Americans are at their core essentially hopeful and believe that the future will be better than the present. And we just don't want to see the future get worse. It's just not in our nature. And right now, all of this coronavirus stuff is making people feel like, well, the future is going to be worse. So I just don't want to even think about that.
And Nick, to your point, I like the way that you kind of divided it into pre-vaccine versus post-vaccine. I actually think to a certain extent that the approach is the same in both scenarios. Pre-vaccination, you're trying to get tests out to those populations who are at highest risk for mortality. So getting it out to senior living facilities, making sure that certain people who are at high risk are able to get tested. And also, at universities and schools, so places where people are going to be more likely to be congregating together, you want to make sure that those people are testing negative to the extent possible. And the same goes for post-vaccination, right? You probably prioritize vaccines to the elderly populations, those with pre-existing medical conditions who are most at risk of mortality. And you, in some way, prioritize vaccinations to people who are, for whatever reason, forced to be in larger groups more often. I think the approach is still, like Will said, prioritizing certain populations. And I think those populations are probably the same before the vaccination comes and after vaccines come.
I don't know if you've seen this, but Fox Media put out a chart to try and help people understand how they should be thinking and possibly behaving in different situations. So it runs from lowest risk to highest risk. Lowest risk being home alone or with housemates, moderate risk outdoor activities, higher risk outdoor gatherings, highest risk indoor gatherings. There's a couple of things that are obvious in every single one of those categories. Wash your hands, number 1. Number 2, if you're not at home, you're to be 6 feet away from everybody and everyone. And if you're not at home, number 3, wear a mask. We don't even have that yet. So when we think about the pre-vaccine world, folks' understanding of what appropriate behaviors are, we still have a long way to go just there. What can we be doing that we're not doing now, either as a state, a county, or a federal government, to help people understand behaviors that will help us all get through this together?
One thing we haven't talked about yet this week is contact tracing. And it's not a silver bullet. It's not a total game changer. It's part of an overall constellation of solutions that can help improve things or mitigate things until we get a vaccine. And one good thing is that perhaps now that we have an increased number of contact tracers at the bigger counties, and they've now been trained. They're still maybe even hiring some more. That they're able to now follow up on new confirmed cases, do that kind of retail contact tracing work, talk about isolation to the cases, work through the quarantine list on their contacts, and perhaps the people that get a direct conversation from a county health department will behave in a particular way that's good. You know, we've seen plenty of examples of like the clubs over the 3-day weekend in downtown Scottsdale and things like that, where people are just pretending there's not a pandemic or don't care, whatever. There's a chance the contact tracing can help improve things. It's not a silver bullet. It's not going to stop this in its tracks, but it's something that's improving, and it's something that we could get better at. And it's something that other states are far better at than we are. You look at in New York, for example, they didn't just use the regular federal guidance to determine whether you're in phase 1, phase 2, phase 3. They put their own criteria in there, like the number of contact tracers per 100,000 population. And so they've got a much more robust set of contact tracers that are out there working with members in the community who've had diagnosed with the illness or their contacts. And so I expect that those places will do better than places like ours, where our elected officials have gone just lock, stock, and barrel with the federal guidance, which doesn't even mention contact tracing. That's an area where I think we could make some improvements. Another area that I think would help is if our governor would rescind the executive order that prohibits local jurisdictions from making interventions in their own community. They were elected in these jurisdictions, whatever city you're talking about. The city councils and mayors were elected to make decisions for their jurisdictions, and they're prohibited from doing that right now. And so that's an area where I think we could be improving as well. So contact tracing is getting better. If we were to allow local jurisdictions to set their own parameters, like they do with zoning and certificates of occupancy and all sorts of things in their local jurisdiction, I think that would help things make some differences. I think that goes to your question, like what could we be doing? Those are some policy changes. Investing more in contact tracing, even though recognizing it's getting better. You know, the CARES Act is funding a lot of that, which is a good thing. I think a lot can be done at the local level that's prohibited now.
Fortunately, the state was awarded, I think it was like $150 million from the CDC to actually go toward contact tracing and other kind of disease surveillance interventions. So we don't know exactly where all that money is going to be going, but it's a promising development. I think the money came to the state. They at least announced it last week. And to your point about local jurisdictions being able to have policymaking authority right now, I couldn't agree more. We know that this is a global pandemic, but it also, in many ways, is a local issue as well. Pandemics are global and local at the same time. And we see that, especially in the charts that we were discussing earlier that ASU has created, that a statewide blanket approach to this might not be appropriate for every single jurisdiction within the state. It's great that we have guidance from federal partners. It's great that the state is giving guidance to certain jurisdictions, but without the authority to be able to create policy that can help to further mitigate the spread of the disease in counties or in jurisdictions where it's still going up, we're really missing out on a critical tool in the toolbox for areas where the spread could be increasing.
Nick, what should we be doing now?
I would like to say speaking with one voice, but I'm aware that that's just not going to happen. People are living different pandemics. There was a story recently just about how based upon where you live, you're more likely to know somebody who had an infection versus not. Depending upon which racial groups you are, you're more likely to know somebody or less likely to know somebody. We're all living different pandemics. I think speaking with one voice would be helpful to communicate just standard things that we can do in places where the highest risks are. Will, you started out by saying congregate settings like nursing homes. So we take places where they're enclosed, they're crowded, and they're close contact. We just let everybody know that's your greatest risk and keep hitting that message. So gyms, places where you're going to be in close physical proximity with somebody for an extended period of time, like getting your hair cut. Well, okay, now you've got to take some extra steps. You've got to do things. The amount of regulation that's gone into sort of trying to protect these enclosed, close quarter places is a lot, but the amount of hue and cry over having to wear a mask when you get your hair cut has been impressive as well. I just feel like we need to consistently hit the same message again and again, not to be afraid, but be aware. We're in a pre-vaccine pandemic era. So we need to protect ourselves whenever we can't maintain physical distance. We need to wear a mask when we're going to be in close contact with somebody and try to avoid crowded places as much as possible. I also accept and believe that most people are doing this. I think the ones that we see out and about not doing it are the minority of people who feel somehow that this is all overblown. Most people are doing what they ought to be.
Yeah, that's right. You can have a video of people clubbing in Old Town Scottsdale and that goes viral, but video of people social distancing, doing things right, videos like that don't go viral.
Right. And if people got together this Memorial Day weekend and hung out in the backyard and kept 6 feet from each other, sat down at a table and waved hi, I mean, is your risk really all that much worse? I mean, you're keeping physical distance, you're outside, okay, it's great. You went to the beach. You kept, 8 to 10 feet away from the next person. I don't feel like these are the greatest risks. Getting into a bar and sitting next to somebody while having a loud conversation over music, okay, that's probably not that smart.
We got to talk about this. It's a big deal. The president said churches should open immediately. It's an interesting topic because, like, my parents are in their mid-80s. A lot of their social network comes out of the church and the faith-based, the big part of their life. And so I've been helping putting together the plan to present to the senior pastor about what it is that they think they should be doing to open safely. And so we've had Zoom meetings once a week for the last month. So I've been working my way through that process to thinking through how it can be done safely. And depending on how the layout of the church or synagogue or whatever, I think there's ways to make it so that if you are thoughtful about it, just like these retail stores and others, manufacturing facilities, if you're thoughtful about what you're doing and how you're doing it, you can create an environment where people can get some of that part of their life back. The social connected and the spiritual part of it, wearing masks. That's pretty easy because you reinforce what you're already teachings of this church is that you protect others. So they were wondering, well, what if people don't want to wear a mask? I said, well, you can just reinforce it by saying this is just behaving in the way that we've been talking about all these years. Having the right kind of hand washing facilities. How do you bring people in so that when you start a service, there's not a bunching up at the door? Screening for temperature, the beginning and a symptom check. And then how do you deal with people who are coughing and they say it's a chronic allergy? How do you deal with that in that kind of environment? And so we're working through all those details, and it seems to me that it's doable. It's going to be different. I think it's a doable thing. So that's an area where I think asking what is it that we could be doing, it's really important to a lot of people.
My experience over the weekend, I got to head out to Home Depot and head out to Lowe's. And the point of the story is that I didn't see a single mask on a single worker at Home Depot, and I didn't see a single worker without a mask at Lowe's. I don't know if there was this particular one or whatever, but that was my experience on these two different places. The point of the story is you can be responsible and reopen your church or your business or your restaurant, but you need to have this consistent communication that we live in a pre-vaccine pandemic, and here's the steps we expect you to take now. When your focus is most on we got to reopen or we got to get back to our daily lives or nobody's going to tell me what to do, well, then you're changing the story. The story really needs to remain that we are in a pre-vaccine pandemic that we all need to take steps on, steps to protect ourselves, steps to protect our loved ones. I feel that's where we've lost this ability to influence our conversation because the story we're all telling is a little bit different. And I hope we can continue to take these reasonable steps to minimize the spread of this virus.
Nick, Will, and Marcus, we cannot thank you enough. Every 2 weeks for the past 2 months, you have been there for us, putting the daily onslaught of news and numbers through the ringer and providing interpretation and insights. We have consistently received strong audience feedback that your contributions to this dialogue are some of the most balanced and insightful out there, which is why we're looking forward to continuing this series with you. In the meantime, don't hesitate to delve into our back catalog of episodes. Each week between roundtables, we dive deeper into key community health determinants, like last week's already highly downloaded episode on affordable housing, an area already in crisis before COVID-19 that is more challenging than ever now. And there is so much more to explore related to community health and well-being in our other episodes too, including guests from across the state and national experts too. Visit us on the web at vitalysthealth.org/podcast. Check out all of our current and past episodes on Spotify, or simply reach into that podcast app you are using right now and select another show to find out what's going on related to health and well-being in Arizona. That's it for this episode. The takeaways from this dialogue belong at the family dinner table as much as they do in your place of business, in city and town halls, and in the domains of healthcare and public health. So please share this independent episode far and wide. Subscribe to the Vitalyst Spark podcast to get notified as soon as new episodes are released. And don't forget, the Vitalyst Spark is also now on Spotify, and you can subscribe to be notified of new episodes there too. In the world of podcasts, you can give us your feedback on Apple Podcasts, Google Podcasts, Stitcher, Overdrive, or wherever you get your podcasts. You can also give us your input the old-fashioned way. Your corrections, complaints, and compliments are all welcomed by emailing us at feedback@vitalysthealth.org. Finally, remember this. With great responsibility comes great power. We'll see you back on the road to well-being soon.